conference schedule, we'll be moving to a panel discussion on anesthesia and related care activities. So our panel moderator is Dr. Gaston Nyirigira. He's a senior consultant anesthesiologist and pain specialist at King Faisal Hospital, Rwanda, and senior lecturer at the University of Rwanda and advisory board member for the Operating Room Global and chair of the Postgraduate Medical Education at Africa Health Science University. And I would like to invite Dr. Gaston. Dr. Gaston, over to you.
Thank you. Thank you very much, Dr. Nebiu. And it's a pleasure to be here with you and leading this panel discussion. And the panel discussion is normally on advancing anesthesia care in LMIC, innovation and workforce development. So with this panel, we have only 45 minutes, and I will introduce the panelists, and then we ask questions to panelists. That every question to each panelist will be only 2 minutes, so that we respect time. So on the panel we have Dr. Elnara Gurbanova from Kazakhstan. She's a medical doctor, anesthesiologist, and AHSU specialist. She's a head of operating unit in Kazakhstan and Kazakh State Medical Academy in Kazakhstan. Please welcome on the panel. So the second panel is Dr. Jackson Ndekezi Kwizera from Rwanda. Is a medical doctor and consultant anesthesiologist and pain specialist fellow, King Faisal Hospital, Rwanda, and he's the head of anesthesia and critical care department. TORG, he's a quality assurance review support officer and TORG research operations and chairperson of TORG Rwanda chapter. Please welcome Dr. Jackson. We are also together with Siraj Ahmed Ali from Ethiopia. She's a holder of Bachelor of Sciences, Master of Sciences, PhD fellow, and the lecturer of anesthesia at Dilla University, and PhD in anesthesia fellow, University of Gondar, and is the president of Ethiopian Anesthetists Association, special projects coordinator, and theology in Ethiopia. We are also with Assistant Professor Narsen Rizki Arefine from Ethiopia, a holder of Master of Science, Advanced Clinical Anesthesia, Assistant Professor of Anesthesia, University of Gondar, Ethiopia, and a Director of Theology Research Operations and Strategy. So please welcome Assistant Professor Narsen. And then the fifth panelist is Hele Mariam Gerechao Tesema from Sierra Leone and Ethiopia. He's the Associate Director, Ethics and Compliance, Theology Research Operations, and the Vice Dean for Research and Continuous Education Program, and Senior Anesthetist, Lecturer, Researcher, Koidu Government Hospital in Sierra Leone, and Dilla University Hospital in Ethiopia. So please welcome all the panelists here, and the discussion will be going smoothly. I hope everyone is connected, and remember to unmute your microphone when you're going to answer the questions. So as we said, this is a panel for the theme, Advancing Anesthesia Care in Low and Middle Income Countries, Innovations and Workforce Development. So I'll be asking some questions to, we have the first round of questions, and we're talking about workforce development and system level challenges in anesthesia. So the first question is addressed to Dr. Elnara Gurbanova. So Dr. Elnara, what are the major anesthesia workforce challenges you face in Kazakhstan, and how can these inform strategies for other LMICs? The floor is yours.
Good day, good afternoon, good evening, wherever you are in the world. Greeting from Kazakhstan. I'm honored to be a part of this panel today, especially on such timely and important topic. First of all, thank you for inviting me to be here today. And let me tell a little about my country. Kazakhstan is the 9th largest country in the world by land area. Total area is about 2.7 million square kilometers. It is the largest landlocked country globally. Kazakhstan has a population about 20 million people. There is 874 medical facilities across the country, and approximately 2,600 anesthesiologists are currently employed. There are 6 medical universities operating in this large area, and in my opinion, this is the reason of the first anesthesia workforce challenge in Kazakhstan. This is a geographic imbalance. Kazakhstan faces a significant geographic maldistribution of anesthesiologists, with most professional concentrated in urban centers. We have 3 urban centers in our country, while rural and remote areas remain critically undeserved. In Kazakhstan, anesthesiologists are the top 5 most in-demand specialties. The demand of anesthesiologists in 2024 was about 300. Geographic imbalance isn't about maldistribution of anesthesiologists. Cities like Almaty, Astana, and Shymkent, this is the biggest city of our country, generally have better access to high-quality anesthesia equipment, advanced medical technologies, and well-stocked hospitals due to more centralized funding and infrastructure. The second challenge, this is the quality of postgraduate education and continual medical education. In Kazakhstan, it's mandatory for all medical specialists to complete at least 120 academic hours in every 5 years. However, this course often take on a formal character and does not provide necessary level of theoretical and practical knowledge and skills. The third challenge, I think, the absence of unified registry of anesthesia-related complications. This is significant for our country because square of our country is very big, and the population is about 20 million. A comprehensive registry would allow for better monitoring, analysis, and prevention of adverse events related to anesthesia, ultimately improving patient safety and quality care. The next challenge, this is the low salaries and motivations issues. In recent years, salary in our country have increased, but inflation and constant rise in prices have effectively reduced this increase. Many anesthesiologists are leaving for private medical centers, where the salary is higher and the workload is lighter. The migration of anesthesiology, for me, is a very big problem, and solving this issue requires not only salary increases, but also the creation of more attractive and sustainable working conditions in public healthcare institutions. This will provide long-term motivation for specialists to remain in these institutions and help improve the quality of medical services across the country. Based on Kazakhstan's experience strategies, the recommendations for low middle income countries are next. optimizing workforce distribution, improving the quality of postgraduate and continuing education, establishing a national register of anesthesia-related complications, retaining professionals in the public sector, equitable distribution and maintenance of equipment, and develop, if it is possible, a national anesthesia and critical care strategy or politic. Thank you very much.
Thank you, Dr. Elnara. So, yeah, that's a clear, briefing of the station, the situation there. Would like to hear from Dr. Jackson. So, Dr. Jackson, in Rwanda, and you have probably a view of the LMIC. So, how can hospital-based programs in LMIC be leveraged to expand the anesthesia workforce while maintaining high standards of care?
Thank you very much. Let me start by thanking the organization of this conference and taking this question. I think it would be easy to me because we have CANEXA. CANEXA is the College of Anesthesia for East, Central, and South. Southside to use utilize hospital-based training schemes that helps that is helping hospitals to train GPs or whoever is into the system being paid by the hospital, and in the end get to contact with the existing staff that are training those staff. In the end, they become the anesthesiologists. Of course, there are exams and all the milestones that every attendee must be achieving on a daily basis. But training someone who is your colleague, expecting them to be like your colleague in the end of their training, being in the same setting, like hospital-based training. The other thing that is really helping with that is you just help the trainee to achieve their milestones, being like a colleague, friends, and in the end, get to achieve their objectives. With that, this helps again to maximize or use the cost-effective way of resources. For example, you may use low cost simulation scenarios, low cost mannequins. You may simulate like very similar cases. The other impact, very big impact of this mode of training, hospital-based training, is that you also have people around you who are really eager to help you because they are friends. You're sharing everything. Another very important point on this is that you keep observing the way your trainees are growing from one point to the other one, how they are progressing in achieving the milestones. So with this model of hospital-based training, the other thing is when there is kind of independent board of examination, everyone is striving to get like the plight of the hospital, of the institution. You need your colleagues or your trainees to be achieving a high level of training. Another very good point in that is using like this hospital-based training helps to minimize the cost of like fees, transport, inviting external professors that are needed to come in. But whoever is in the hospital being employed can be helping in delivering, like lecturers or on-job training, all these courses. And then the way you assess your trainees is kind of very intact and very objective as you see how your colleague, your trainee. Allow me to use the colleague, because as you work with him or you work with her, your trainees, he or she becomes your colleagues. In the end, you get to know how they are progressing, and you are able to sit and brainstorm how you need them to progress. That is another thing. The other thing is context-specific training. You know what is missing. Like one part of the puzzle that is really being left out. For example, I will not take my trainees whom I'm working with to start thinking about maybe AI-based anesthesia, for example. This will be just far away from the reality or the context I'm working in. So the thing is, you train them basically on more common condition, how you manage them, and then upgrade using evidence-based medicine. The other thing is tele-anesthesia and remote supervision. For example, our trainees with Kanexa, they are being trained sometimes with remote PowerPoint presentation, remote case discussions, and we have some of the volunteers from US who may be delivering their presentation being far away, and in the end, help us to deliver some of the updates in terms of anesthesia. Thank you so much.
Thank you, Dr. Jackson. So I'm reminding the panelists to use time, like don't go beyond 2 minutes, because this will disrupt our planning. So yeah, thank you for the highlight. And the next question to Siraj in Ethiopia. As the president of Ethiopian Anesthetists Association, what approaches are being used in Ethiopia to train and retain anesthesia professionals in underserved areas? Siraj?
Thank you very much, the moderator, for your invitation. Yes, can you hear me?
Yes, please.
Okay. Thank you very much for your invitation and moderation. So I'm Siraj from Ethiopia. Just respond to your questions regarding the anesthesia professional training, especially to deploy in the underserved areas. Ethiopia, a country in Eastern Africa and developing country, designs various strategies to train anesthesia providers in various levels. And there are also various strategies also to retain them in the areas where most physician anesthesiologists are not capable of working there due to limited number of physician anesthesiologists and the likes. So especially from 2012, the country has, the Ministry of Health assessed the number of anesthesia professionals in the country, and the health facilities also desire to provide surgical services and design various strategies. And one of them is to maximize the number of health institutions to train anesthesia professionals. So in 2012, there are only few higher education institutions where anesthesia program is delivered, which is 7 or 8 institutions only. But now there are 30 higher education institutions to provide anesthesia trainings, including 8 residency programs in the country. So maximizing the number of educational programs in the country is one way of increasing the number of anesthesia workforce in the country, where most of the health facilities, especially the primary ones, are underserved areas or remote districts of the country. So maximizing the number of programs in the country is the priority or the strategy that has been implemented in the country for the last decades to increase the number of professionals in the area.
Yes, thank you. Thank you very much. That's a good highlight. So we let's hear from Halemariam, the child Tesema. So is having like 2 sides, like 2 views, Sierra Leone and Ethiopia. So in your dual roles in Sierra Leone and Ethiopia, how do you navigate the complexities of anesthesia workforce development in fragile or under-resourced health systems? Over to you, Tesema.
Can you hear me, please?
Yes.
Okay, all right. Thank you for brief introduction, and I'm really privileged to be here on this one of the successful and wonderful events of TORG 10th anniversary and annual conference. As it has been mentioned, my name is Halemariam, both working in Sierra Leone and in Ethiopia. So as far as the time concerned, I will concentrate on the Sierra Leone aspect. So my question to just navigate the task force in anesthesia, I believe that surgical care is like a silent pandemic because the access to surgery is really limited due to the fact that the task force is really limited, especially in low and middle income countries. Why I'm saying this, the Global Commission, Lancet Commission predict that by 2030, we're supposed to have 20 anesthesia provider per 100,000 population. But in fact, the data is showing that we only have 1 anesthesia provider per 100,000 population, which is sometimes even below 1. So this is really alarming. So having said this, what are the way forward for this? For me, I can say we must have 4 way out approaches. The first supposed to be context assessment. We have to assess and we have to find evidence to showcase that the gap in infrastructure, the gap in task force, and the gap in service delivery will be the first one. The second one, we have to leverage partnership, as we are doing in Sierra Leone. Now in Sierra Leone, we have been providing anesthesia academic program in collaboration with NGOs like Partners in Health, NGOs, Mercyship Global and Mercyship Africa, and also the Ministry of Health and Sanitation of Sierra Leone. So we have been partnering in increase the task force of anesthesia. The very important and the third point, which I believe is that training, capacity building, mentorship, and retention mechanism. So things has been tried to increase the capacity, the task force of anesthesia care in Sierra Leone, that we have mentorship program, we have fellowship program also. Before they even went to school for anesthesia, we trained them for 1 year for them to increase the awareness and understanding of anesthesia and perioperative care. But most importantly, which the major gap I can see in lower middle income country is retention. The retention of anesthetists. anesthetists, most of the anesthetists are they have high intention to leave their profession and high burnout incidents when you see evidences across the globe. The reason being there is no career pathway. But in Ethiopia, I can say we have master's program, we have PhD program in anesthesia. But when it comes to other lower middle income countries, especially in West Africa, it's only limited in bachelor program. So there is no way for the anesthetists to upgrade and to improve their career pathway. So they will shift their profession going to public health or other disciplines. This was also one of the major gaps which I observe, and also study supports me. The most important one, the fourth point, is that policy and advocacy. We are working in advocating the anesthesia program in National Surgical and Obstetrics Program. We are advocating the Ministry of Health. We are advocating the partners. We are advocating the private institutions even to give emphasis and attention to the anesthesia care, because surgery without anesthesia is nothing. So this is the most four important point. I put us way out to increase the task force of anesthetists across lower middle income countries. Thank you very much. Over to you.
Great. Thank you very much. Thank you. Thank you, Tesema. So now let's talk about innovation, because this is the thing. And we're going to go the second round of questions, and then we know what we are facing in anesthesia practice in terms of workforce and the target we have and challenges we have. And then how about innovations, patient safety, and future directions? I know you have some highlights on that, and would like to hear from Kazakhstan. What innovations, whether in technology or technique, are improving anesthesia safety and training outcomes in your setting? And this, I would like to be straightforward and don't make this discussion long, and tell us like straightforward what is the innovation and patient health, safety, and future directions. Over to you, Dr. Elnara.
Thank you for the question. Some points about innovations or in technology and technique in Kazakhstan. First of all, I think this is a simulation-based training. In some regions, the opportunity of use mannequins is limited now, but in big cities we use simulation-based training in our center, of course. For example, at our center we use CPR mannequins for code blue education and regular staff training. Second, I think the online learning and international collaboration. For example, TORG, the participation in webinars of TORG and the European Society of Anesthesiologists. Third, this is the adoption of protocols and checklists. For example, surgical safety checklist. We adopt a surgical safety checklist in our center from 2021, and we have some problems about the cultural change and needed to ensure that the value of this checklist. In addition, we have national standard for anesthesiology and intensive care. It was approved by Ministry of Health in 2023, and this standard work in our country. In our center, we perform about 9,000 surgeries every year, and we also working to integrate modern technologies in our clinical practice. We for 2 years we have been used to video laryngoscopes and currently training our staff in endoscopic intubation techniques. This year we expect into delivery of an ultrasound machine to support ultrasound guided central venous catheterization and nerve blocks. And our center is the clinical base of medical university of our city, and these new technologies and techniques provided in our center every year and every day. Thank you.
Great. Thank you. Thank you very much, Dr. Jackson. So how can quality assurance frameworks be integrated into anesthesia practice to improve safety without overburdening already strained systems?
Thank you so much. With these low and mid-income countries, I think that's where we need to be heading with quality assurance and keeping all this training, developing workforce. But in the end, you need quality assurance that helps you to improve the safety of patient we are giving anesthesia, and safety of ourselves and safety of the institution we are working in. So with that, as my colleagues talked about it, you need policies and procedures in place. Of course, they will be adapted to the settings and contexts, but again, keeping in mind we need to scale up with the global contexts. In the end, you also need to adapt these accreditation processes and the regulation that are in place. Of course, meeting up all the requirements, what really is needed to be giving this anesthesia, who gives anesthesia, what are the requirements, what are the qualifications, who do you need to be around when you're giving anesthesia, and then putting into practice this, you need all these policies and procedures, guidelines to be used, and then evidence-based medicine that can help, again, to go along with all this. Again, with quality assurance, you need to be advocating for patient safety in terms of bringing new or innovative ways of upgrading what you've been doing, and then looking forward to improving in terms of workforce, in terms of well-being, in terms of equipment, and involving the record administration of the institution. Thank you.
Great. Thank you, Jackson. So, Siraj, how can collaboration between professional associations and academic institutions drive innovation in anesthesia care? Could you tell us more, maybe in Ethiopia, your experience?
Thank you again. So regarding the professional associations collaboration with higher education institutions, special implementation of a curriculum to produce qualified professionals is very important. In our country, for example, we have various sessions that we are using to collaborate and share innovations from one institution so that we can escalate and adapt to the other institutions. There are various sessions, and one of the most important sessions is national quality academic or education quality workshops or forum. So in that case, academic programs in various parts of the country that are training anesthetists in various programs like the undergraduate, postgraduate, master's program, the likes, will have an opportunity to share their experience, innovations in their teaching, learning, clinical implementations of various implementation projects will be shared to the other institutions, where others also learn that new innovations or activities and adapt to their own institution. And the other point that the associations can be used as an intermediate of sharing experiences and even the students' activities, like during their research, for example, in their master's program, students will conduct research for their completion of master's. So, and in new innovation may happen in one institution, and that will be presented in the national conferences organized by the association, and will be adapted to the other institution and used as the best experience. And if it's a solution for improving anesthesia services or even the training, it will be very nice to be used there. And the other point, the association also facilitates academic program accreditation, quality improvement activities, and nationally or even the international associations also work on that. There are certain standards, guidelines, and program. For example, in Ethiopia, there is a program accreditation worked for the last 2 years, and now our programs are introducing to that. The association has collaborated with the Ethiopian Training and Education Authority to produce and develop the guideline. Then that guideline is used to accredit anesthesia programs in the country. So the association is working to collaborate, coordinate, and used as an intermediator of the programs in the country. One program cannot do anything with it alone. So collaboration of those programs in the presence of the associations, not only national or internationals also can work on that. This is a very fertile ground to introduce innovations and academic improvements so that anesthesia service in the country and the continent and also in the globe can be improved. As till now, the surgical workforce, not only anesthesia, the surgery obstetrics also is very limited and below 10 still in the most of the countries in
yes.
Thank you.
Great. Thank you. So Tesema, so sometimes we talk about innovations, we talk about process to improve patient safety and anesthesia practice, but yeah, would you be happy to tell us like specific innovations or process improvements that you have seen succeeding in improving anesthesia delivery and patient outcomes in your region, please?
Thank you very much, Dr. Gaston. WHO say healthcare is human right, but I personally prefer to say quality healthcare is human right. Why I'm saying this, that every care we give without quality, we know one day we will fail. So for that sake, in Sierra Leone, we try some innovative ideas to enhance the perioperative care program of the patients. So one of the first things we did was we implement enhanced recovery after surgery care program for cesarean section. So currently the preoperative, intraoperative, postoperative cesarean care program has been protocolized in Sierra Leone once we start this implementation and initiative. The second implementation we did was pain as a vital sign initiative. This one included to incorporate pain as on the vital sign sheet to teach our nurses, anesthetists, surgical team about pain assessment and management. And very importantly and notably, we also started regional analgesia block as a sole pain management. So this pain as a vital sign initiative was also one of the wonderful job we did. In fact, I can say. The third one was perioperative care starts from OPD, as we all know, but most of the time anesthesia care starts at admission, after admission, I mean. So we started anesthesia clinic in Sierra Leone. So now all the patients who are going to be admitted to theater need to see by anesthetists at the OPD level. to track change, to see the clinical condition, to have proper consultation and laboratory workup. So this implementation of anesthesia clinic by far decreased our cancellation rate by more than 20%. So that was one of an initiative we did. The last but not the least one was, as a clinical hospital, as it is not an academic center, there was no multidisciplinary morning briefing for surgical patients. Now we start an initiative called multidisciplinary team morning briefing and care handler. This one, where all the surgeons, anesthetists, peri-op nurse, and other clinicians to sit together and to discuss the patient just before incision. So this initiative has brought a lot with respect to effective communication, with respect to continuity of care, with respect to even incidence reporting and future learning. So this initiative brought us really a change. I might not tell you here to stand still and say change. A lot has been changed. So where you are in low middle income countries, there is limited anesthesiologists, where you are giving care most of the time by task sharing and task shifting, where you are in a remote area where access is really challenging. This initiative brought a lot in perioperative care. So thank you very much. That has been what has been done here.
Thank you very much, Tesema. So I think we're running out of time. We have only 3 minutes left. So I would like to invite at least one question from the audience, from the participants, and then respond it straightforward, just to make a summary of this panel discussion. Is there any question? Okay. Thank you very much. I think we discussed a lot, and mainly we have talked about the workforce strategies and around the LMIC. We have heard from different regions and across the world, and so the workforce expansion strategies, it has to balance with the quality and the quantity, of course, and then use of technology and innovation to fill training and core and care gaps. So we had from Jackson with the Connexa having the region bodies and those professionals that encourage hospital-based training just to increase the workforce, and that's one of the strategy. And then building systems for ongoing professional development and quality assurance, which is important. And then the collaboration, the importance of regional, international, global collaboration. Here mentioning TORG, because it's been monumental in doing this. Because when we gather online talking about like something really sensitive and a topic, Pakistan come, Rwanda, Ethiopia, Burundi, everywhere. Like we share, that information is really important in terms of like what is happening here, what is happening at their side of the globe. We share in cases, we discuss, and then we take some message at home. So I think this is really important. I would like to thank all the panelists and your contribution is really amazing. You took your time to prepare this and then to share, and then your time. We really thank you very much, and we thank everyone that is participating through this platform. And we thank TORG and King Faisal Hospital Rwanda for organizing this. And I think this panel is over, so I will hand over to the moderator of the day and Dr. Nebiu. So the floor is yours. Thank you very much. Thank you for your contribution.
Thank you very much, the panelists, and I think it has been a hot discussion. So all topics has been raised, even though it is a very short period of time. So now we will be heading to our tea break, and we'll be convening again at 10:20. So please be on time, and we will be also heading to the presentations, and the presentations will be kind of very interesting, and everyone will have like questions and a Q&A on the different topics. So take your time and let's be on time at 10:20.